This is the Exam Room Podcast. Value-based care has been positioned as the future of healthcare, promising better outcomes, lower costs, and a shift away from volume-driven care. But is it working? Or has it become another complex system that's difficult to sustain in the real world? In part one of this two-part series, host Dr. Rhiannon Winsor sits down with Dr. Ben Schwartz, an orthopedic surgeon turned healthcare leader, to take an honest look at value-based care from the front lines. From bundled payment models to CMS policy, this conversation explores what's working, what isn't, and why the reality of implementation may be far more complicated than the vision.
Welcome back to the Exam Room Podcast. There's been a growing conversation and in some circles, backlash around value-based care. Is it working? Is it sustainable? Or has it become another healthcare experiment that's too complex to scale? Today, we're joined by Dr. Ben Schwartz, a fellowship-trained orthopedic surgeon who transitioned from 17 years as a high-volume hip and knee surgeon into physician leadership, focused on clinical governance, care model design, and translating value-based principles into real-world operations. Dr. Schwartz has participated in CMS bundled payment models, advises on ambulatory strategy, and works at the intersection of quality, access, and financial sustainability in specialty care. So today we're asking the harder questions. Is value-based care failing? CMS double down or step back? And if it really is better care, how do we make it work for everyone? Dr. Schwartz, welcome to the show.
Thanks for having me. Appreciate the opportunity.
Yes, I'm excited for a conversation. Before we get started, tell us a little bit more about your journey.
Sure. So I was an orthopedic surgeon for 17 years. I specialized in hip and knee replacement surgeries. For the first, 10, 12 years of my practice, it was a fairly standard private practice. Show up, see patients, do surgeries, take call, go home, and don't think too much about practice management issues. Don't think too much about, am I creating value? Am I delivering value? Because I felt like the feedback I was getting from patients was the indication of whether or not I was delivering value and good quality care. My practice entered into the BPCI-A model, so I got a taste of what real value-based care was. That turned me on to the idea of, hey, there's an opportunity here to do things more efficiently within the practice. There's an opportunity to incorporate technology. It was around the time that digital health was really taking off. So started doing some advising and investing in tech companies, health tech companies as well, and started to take on some leadership positions within my practice, within national organizations, within the hospitals where I was operating. So everything just sort of started converging around this idea of value in healthcare, of practice management issues, of leadership issues, of technology, and that kind of became a passion of mine and led me to leave practice and focus on that full time about 6 months ago now, 5 months ago, 6 months ago now. Yeah.
Wow. So you mentioned the BPCI model, which for our listeners is essentially a bundled payment model where Medicare sets a target cost for entire episodes of care. What actually worked and what didn't?
Yeah, I think if you look, sort of globally at the BPCI model, it did save costs. So the cost came down. A lot of that was by reducing post-acute care. So instead of sending patients to a nursing facility post-operatively, send them home. That was really the biggest driver of costs. And we know that that's safe. It's proven to be safe. In fact, studies show that you actually are at higher risk of being readmitted or having a complication if you go to somewhere other than home after a joint replacement surgery. So that was successful. What happened is that when CMS had to reconcile everything and pay surgeons for the cost of care, the reconciliation payments kind of wiped out the savings. And so at the end of the day, what happened is the payments basically had to be ratcheted down by CMS. So you became a victim of your own success. Your target price shifted lower and lower to make sure that there was, still some savings there. And I think over time, a lot of surgeons dropped out because of that. And that's sort of what made the model less successful is it wasn't that costs weren't saved, and they studied it as well. Quality was pretty much maintained these programs. So you were doing these things without sacrificing quality. It's just that by the time you kind of reconciled everything, the savings just weren't there at the end of the day, or you had to squeeze so hard that people just didn't want to participate because it was voluntary. For me, on an individual level, I had success within the program. I didn't, feel like I had to change a lot of what I was doing going into the program, and that's a part of the reason I did have success. But ultimately, at the end of the day, the practice made the decision not to continue on with the program because it's administratively complex. It's hard to peer into the future and see where the pitfalls might be. And I think ultimately, at the end of the day, the juice wasn't worth the squeeze to leave fee for service or to stay out of fee for service for those patients.
So some are saying that value-based care is a failed experiment from your perspective. Is that fair?
I think it depends on what you look at. I think people would argue that some of these ACO models have been successful in primary care. I think for specialty care, again, there's been some success. It just hasn't been sustainable because of the mechanisms that are in place. And I think that's part of the reason that there's backlash, is that anytime you have something that is kind of built up as this hype, and I think it became value-based care became the narrative of, okay, this is how we're really going to solve healthcare. Fee for service is really the problem, and we're just incentivizing care. We're not or more care. We're not incentivizing quality. It's volume over value. We need to have pay for performance. And I think everybody was excited or thinking, yes, we finally figured it out. This is why healthcare is so expensive. And if we get people off of this sort of just get paid more to do more idea and onto this value-based care idea, we're going to solve things. And that, I think, was unfair to the concept of value-based care. I think it was an oversimplification of the forces and why is healthcare expensive and where are these opportunities to improve things. And I think the backlash came in because it just didn't live up to the hype, and people that participated in the models didn't feel like they were being treated fairly because the target prices were shifting down. And it gets one of those things where you keep hearing about this is going to revolutionize care. It's going to revolutionize care, and it never happened. Or, it did happen, but it didn't revolutionize care. That sort of people got tired of hearing about this idea of value-based care. The CMS has certainly not abandoned it. They're doubling down. They're changing on the fly. Now we have the lead model coming out. We have the team model that rolled out this year. We have the ambulatory specialty model, which is on the docket as well. So, CMS has said they want everybody, all the beneficiaries, in some form of accountable care by 2030, and they have not back down from that. They just continue to iterate on those programs.
So when you step back, would you say the issue is the models themselves, or they're the way we're implementing it? Is it the expectations are too high? What are your thoughts?
I think it's all those things. I think the models can be administratively complex, and that makes it challenging to participate, and it keeps people from participating if it's voluntary participation. Sometimes the upside just isn't enough to make it interesting to go into the model, or if it is voluntary, you're going to the high performers are going to self-select, and the low performers that you really want to go after are going to stay out of the models because they know they're not going to be successful. I think we're seeing the shift, and we'll continue to see the shift towards mandatory models. That's what team is. And there's a lot of hand-wringing around team in terms of not being successful in that model. And what's going to happen the first year is upside risk only. In year two, you have to take some downside risk. And, if you're not successful, what does that mean? Is there going to be backlash because of that? So I think it's a combination of all those things. I think we also have to take a step back and ask ourselves, are we solving for the right problem? Is it really a fee for service versus value-based care problem? Are we pulling the right levers? Are there other opportunities? Why is healthcare really expensive? And I think it's a very complicated question. And the value-based care versus fee for service part of it is only a part of that question. There are other factors that maybe we're not looking at if you talk about consolidation and some of these other things that drive up healthcare costs.
For sure. So if you were advising CMS today, what might you tell them?
I think simplification, to me, the more simple it is, the more that people are going to participate, the easier it's going to be to stay in the programs, the less administrative expense you're going to see, which kind of eats into any savings you get. And I know it's difficult. I know the goal is to try to design programs that people can't game. But when you start to do that, you realize that there's a lot of opportunities that bad actors, no matter what the payment model is, bad actors are always going to find a way to be bad actors. And I think the more you try to minimize that, the more and more complicated the programs become. So I think, simplify it as much as you possibly can, the administration of it, and then make, targets attainable, sustainable, make sure that people that are high performers aren't a victim of their own success, kind of reduce some of the gatekeeping that we're seeing in some of these newer models, so that there really is collaboration between specialists and primary care providers, is probably where I would start. I wrote recently, and I'm becoming more convinced about this idea of maybe we should test a really simple model that is more like traditional fee for service, reduces the administrative burden, reduces barriers, and see, is all this complexity necessary in order to achieve our goals? Or maybe we should go in the other direction and make things less and less complex and see what happens, and maybe A/B test that. So I don't know if CMS will do that, but it would be curious to me to see if we can, make a really, really simple, straightforward model and compare that against some of these more complicated models.
For sure. So what does success in value-based care actually look like? Clinically, financially, operationally, in your opinion?
Sure. I think it depends on how you define success. And that's always the challenge in healthcare, is that every stakeholder's definition of success is a little bit different. So as a provider, your definition of success is feeling like you're, getting paid fairly for the services that you're providing and getting rewarded for good care and not getting punished for things that are beyond your control, in a model that's easy to administrate from your practice level. I think for CMS, obviously success is high quality care, but also cost controls. And I think that the tendency maybe is to over-index on the cost control, understandably so. But I think for CMS, it's maintaining access and quality, but at the same time, controlling costs or bringing costs down. If you're a patient, I think that's the stakeholder that sometimes, maybe doesn't have as much of a say or representation in these models. Patients want high quality care. They want access to care. They don't want to feel like care is being rationed, or, that they're being kept away from care, to being denied care because it flows to the doctor's bottom line or flows to the government's bottom line. They feel like, look, I paid into this program, for years as I was working. I should have the access to these benefits, and I don't necessarily to have care restricted, or, I don't care how complicated this model is. I just want to get good, high quality, accessible care. And so I think for patients, it's a little bit of a different value proposition that isn't always taken into account. I think the lead model is changing that a little bit with some cost sharing, but I think patients kind of get caught in the middle sometimes.
Yeah, so we have three definitions of success kind of all happening simultaneously. There's CMS saying this is what success looks like. There's providers saying this is what it looks like. And then the patient is saying, well, this is what care looks like, success in care looks like for me and myself.
Yeah, and it's always the aligned incentives issue when you have so many, stakeholders. How do you align all those incentives? It's not always easy. I had a patient in the BPCI program who, knew that Medicare would pay for 3 weeks for her to go to a nursing facility after surgery, and she knew she had that benefit, and she didn't feel like she should be denied that benefit, whether she truly needed it or not. And who am I to tell her, look, you can't do that because you're in this bundle payment program for me, and this is really going to hurt me in this bundle payment program. The patient, that she knew that was her benefit and she was going to use it, and it again, the incentives aren't always aligned, and how do you kind of get everybody rowing in the same direction?
Yeah, so last week we had our kickoff meeting for VB Care, and there was quite a bit of talk about how we need to start focusing more on our high risk patients. Like, what do you think about when you're thinking about your high risk patients, and how do you manage them in this value-based care model?
Yeah, those are some of the lessons that we learned, which I think was another good thing about the BPCI program. I think one of the downsides is it didn't do a great job of risk stratifying patients, unfortunately. The upside was it made us think a little bit differently about how do we optimize a patient for surgery? How do we take somebody and lessen their risk as much as possible? There are things you can change. There's the modifiable risk factors. There are things you can't change, which are the non-modifiable risk factors. But yeah, it made us take a little bit of a step back, which maybe we weren't doing before, to say, hey, this person, yes, they need surgery or they're a candidate for surgery based on the fact they have bad arthritis, but they're not ready for surgery yet because we need to get their diabetes under better control. We need to help them lose weight. We need to counsel them about smoking cessation, all these things that are going to make them more successful, lessen their risk as much as possible, and make them successful and us successful in this program. There's people that you can only lessen their risk so much, and they're always going to be high risk. They have non-modifiable factors, and I think these programs, need to do a better job of taking that into account. It seems to me like the LEAD program acknowledges that and is doing a better job of risk stratifying patients.
So under that value-based care model, are there certain metrics that you're looking for or that you're suggesting as you're guiding others in this model that they should be paying close attention to?
It depends on the model. Some models have certain benchmarks depending on what the model is. I think at the end of the day, again, CMS, care is obviously about quality and patient report outcome measures. I think at the end of the day, cost is going to remain a big part of it, and each of these models is a little bit different in terms of the metrics that they look at. So I think understanding the metrics, if you're going to go into a value-based care program, certainly, do your diligence ahead of time, know what your numbers are, know what your metrics are, know whether or not you're going to be successful. If you aren't, take steps to address things, fix things. Again, I think some form of mandatory value-based care, certainly for Medicare patients, is coming for everybody. And so you may think it's not going to affect you, or you can kind of stay away from it or skirt it, but eventually it's going to come for you. And I think now is the time to understand your data, your quality data, your utilization data, your complication data, your outcomes data, so that you're not scrambling when you're forced into these models, which I think some team hospitals are now finding out.
Yeah, and then there's that concept of being a part of an ACO where you have a group of health centers, and if one falls, they all fall, So then it's not just like looking in my backyard and seeing what's going on, but it's also looking at the other health centers that are in my network.
Yeah, I mean, it's sort of the rising tide lifts all boats, but a sinking boat can also drag other boats down with it. We experienced that a little bit too in BPCI. Hey, we were looked at as a practice. It's not necessarily on the individual level. I mean, it is. You're looking at your individual benchmarks, but at the end of the day, I was responsible for the majority of the savings in PPCIE for my practice, but the way the model was set up, half of that savings went to the practice as a whole to pay practice expenses, and then it was distributed, amongst the surgeons sort of more evenly. So you have to make sure the incentives are aligned. Again, you have to make sure you're not dragging high performers down, and that the high performers, the lower performers can learn from the higher performers. But the incentives are proper and aligned for everybody that's participating.
Yeah, I think collaboration is really key, a key to success there.
Yeah, we're seeing that I think CMS is very much interested in primary care doctors and specialists collaborating more. And this is a question of how do you build a program that incentivizes that, properly. I mean, I've been involved in ACOs here in Massachusetts where, by participating as a specialist in the Medicare ACO, at best I can make 1% more over traditional Medicare payments. It's not as interesting. You're less, you don't pay as much attention to it, as opposed to the PCPs, which maybe have more skin in the game.
You've been listening to the Exam Room Podcast. In Part 2, Dr. Ben Schwartz goes deeper, challenging assumptions about what value really means and why payment models alone may not be enough to drive better care. From physician incentives to real-world practice challenges, the conversation continues with a closer look at what it would take to make value-based care truly sustainable. Be sure to subscribe so you don't miss Part 2.